Can you see my screen?
Yes, that looks beautiful.
Good. Okay. So again, apologize. I'm just going to go through this as best I can here with the slides as they are.
Graham, can you hit the green circle at the top left and it'll make it full screen for you. Yeah.
Thank you. Oh, great, Steve. Thanks. Yeah, I'm using a PC for too long. I forget these things. Okay. Is it best if I condense this then? So to say 30 minutes or so?
We can probably just run like 15 minutes late, so just try to condense it a little bit, but we are very much looking forward to hearing your talk, so just take it as it goes.
Okay, sounds good. Okay, well, thanks. Just quickly about me, I'm a clinical scientist at Philips in CT, responsible for Europe. I've worked for many, many years in the MSK and bone field. Actually, I started with Steve Boyd and working a lot with micro CT and animal models of osteoporosis and disease. I've since moved. I've been with Philips for about 5 years now, much more on the clinical side now, clinical CT, working in all kinds of research projects in CT and different domains. But in particular, where I have a lot of interest is in spectral CT, and in particular with MSK. I think there are a lot of opportunities for MSK applications with this technology. So I would just like to talk a little bit about that today. So just how the clinical CT is working in the routine at the moment, and where we can go or where we are going with spectral CT. I'll explain a bit about what spectral CT is, as well as photon counting CT, which in a way is also spectral CT, but there are some differences, and then how this really applies to MSK, or where we're kind of going with MSK, or we think we could. So computed tomography or CT, for those that maybe aren't familiar with sort of the clinical aspects of it, and that's sort of what I learned in the last years, is really how it's fitting into the clinical workup, and it's really considered the workhorse of radiology. This is something where if you really need to know what's going on inside the body, you'll perform a CT. If it needs to be done quickly, and CTs are quite readily available. So this is why they're really the main imaging in the emergency department. If we have somebody that comes in with a suspected stroke or pulmonary embolism or heart attack or something like this, and time is really the most important factor. That's where it's used. Hard tissues, so bone, of course, calcifications. This is also really seen well with CT. Of course, it's volumetric, so that's an advantage over X-ray, for example. But it also has drawbacks. So, of course, ionizing radiation. This is a concern. So if patients can wait for other imaging, sometimes this would be used. And of course, we don't see really good soft tissue contrast. So, for example, this image here, where you see in the MR image a herniated vertebral disc quite nicely. I don't really see that in the CT. And also with just a picture with the brain, you can see already, okay, a lesion, you can see it, but just characterizing it or getting gray and white matter differences, or subtle lesions are often missed with CT. So this is where often we're in a case where CT is performed first, but then something is inconclusive, or we need to know more, and then other modalities are performed. But that, of course, takes longer for a diagnosis, or sometimes there are contraindications. There are metal implants or something, or claustrophobia, or just availability. So I kind of touched on a bit of this already, where CT is used. So cardiovascular, pulmonary, this is really a big area. So where you're looking at stenosis in the vessels, embolism in the lung, calcifications, things like that, or look for a route for a catheter, for example, for interventional procedure. Stroke, I touched on a little bit, blockages in the vessels, looking at perfusion, so trying to find where there's an infarction or where tissue can be saved. emergency trauma, of course, but also oncology. So these are areas where it's really used, delineating lesions, looking for fractures, things like that. So now there's a lot of uncertainty that I touched on. And for example, you might have, you're looking at a CT scan and you're not really sure, is there something there? There might be something hyperdense, but it's very difficult to tell. Or maybe you see something, but you don't really know quite what it is. You're looking for a root of a catheter and you want to see, is there stenosis, but you get an image like this where you can't really see any contrast. Or you're looking at to look to see if there's a perfusion deficit in the heart, is there an infarction or ischemia, and you see a hypodense region, but you know that this is actually common to see beam hardening in this area as well. So what is it? Or you've done a surgery to remove a clot in the brain, and you see a lesion like this, and you don't know, is there a bleed? Do we have a hemorrhage now? Or is this actually contrast agent that's still there? Or we have a fracture of the vertebra that we can see very well, but is it acute? Do we need to operate? Or has it been there for a while? It's stable. This patient actually can go home. These kinds of things. So what we want to look at or what we're doing now with spectral CT is looking at ways to enhance contrast. So this is what is called a virtual monoenergetic image. And I'll talk about this in a minute, but we're essentially simulating how an image would look if the X-ray spectrum of the X-ray beam would actually be one energy, a single energy. And then we reduce that energy to increase the contrast. And then we can see the iodine up a lot better, and we can see where there's a lesion where we didn't really see it before. We could also overlay an iodine map on this, so we could actually see in milligrams per milliliter of iodine how much is there and make a diagnosis based on that. Increasing contrast, we can now see the vasculature much better, and we can see where we can go with the catheter. We apply, say, an iodine map, and all of a sudden we realize, oh, there actually was beam hardening. There's no perfusion deficit in the heart. Or we can see, well, there actually is iodine uptake in this lesion, so we know that this is actually residual iodine and it's not a hemorrhage, for example. Or in the fracture, we see, okay, here's the fracture, and now we can look at what's called a calcium suppressed image. We remove the calcium signal, and this is kind of like a water image from MRI, and we can see where there's bone marrow edema. So we can actually see that this is an acute fracture. There's edema, and there needs to be surgery or stabilization or things like this. So how does that work? How can we do that? Well, if we would look at the attenuation over different energies of the X-rays. So CT is based on attenuation of X-rays, and the more attenuation we have, the more dense a material is, or the higher the atomic number of that material. And if we look at the average energy of an X-ray beam, maybe around here somewhere, 70 up to maybe 80 or 90 kiloelectron volts, and distinguishing between bone and iodine would be very difficult. But if you look at, for example, pure iodine, which is up here, versus iodine that you would inject sort of as a contrast agent, and that's where the overlay to bone is quite high, but you can see the patterns are quite different. So here's iodine where we get to a K edge. Here's calcium, the K edge is much lower and a different pattern. So if we would be able to scan at two different energies or have two different attenuation values at different energies, then we can essentially tell from the differences in those curves what that material is. And each material has its own attenuation curve. So I won't go too deep into the physics. I just want to show this because this leads on to sort of how we distinguish the materials. But in the region of energies of CT, we're typically seeing two things happen: the attenuation. The photons are either absorbed when it gets to the K edge of the material. The energy is too high to get to any of the outers, but some high atomic number elements will then cause the photoelectric effect to occur. Or with other materials, you typically will have scatter, so Compton scatter. And so we can assume, and for CT energies, it's mainly the case, is that we have one of these two things is occurring, and our total attenuation in a voxel is made up of the photoelectric attenuation and the Compton scatter attenuation in that voxel. And these are both dependent on the density of the material and the atomic number of the material. So iodine is, as it's used as a contrast agent, is very relatively low density, but it has a high atomic number compared to water, for example. Whereas a cyst or something like that would have a higher density, but still a low atomic number. And the Hounsfield unit might be similar, but the atomic number is different, or the density. So this is where we can, if we would say, okay, we add up the attenuations of each type and we scan at two different energies, or we have two different spectrum, then we can solve for that. And mathematically, theoretically, you could, or if you know the profile of the beam, and you can calculate this. And that's the essence of dual energy or spectral CT to determine the materials. So how this can be done, there's different ways. First, manufacturers were doing source-based, so there would be one tube in the scanner would scan at a low kVp, a low kilovolt peak energy, and another at a high. Or you would have one tube that switches very quickly. We do a different technique. We separate the beam at the detector side. So we have two different layers in the detector, two different scintillators, and we can essentially achieve synchronously two raw data sets, a high and a low energy raw data set. And sort of moving forward with this is in the direction of photon counting. That's actually a completely different detector altogether, and I'll get into the differences in a sec. But you can actually bin these energies into 4 or 5 different levels. So what we do is we have a dual layer detector. So we're able to split the raw signal into a high and a low energy signal. We can generate essentially a photoelectric and a Compton scatter image, or raw data set is actually how we would do it, but just for these purposes, an image. And if we would plot for every voxel of this scan, we would plot the photoelectric and the Compton attenuation, we would get a plot that looks something like this. So every voxel lands somewhere here in this image. So if I would be in the liver somewhere, and maybe it's in the venous phase and we have some contrast uptake, it might land up here somewhere. The bone would be over here. If it was a non-contrast scan, it's down here. And each of these vectors, these lines here is a material. So fat, water here is in this sort of range. Water or blood with iodine will be here. Bone is somewhere over here. And if we would combine these with different weightings, then we would get the monoenergetic images. So we would have a very high energy simulated image, or a very low. And this is because at a very low energy, we have a lot more photoelectric effect versus scatter, which is more at higher energies. So what kind of images we have? There are a number of material images, first of all. We can show, so I alluded a bit to the iodines. We can show the concentration of iodine. So actually an iodine map where every pixel shows the concentration in milligrams per milliliter of iodine. We can do the reverse of that. We can remove the iodine signal and look at how the image would look like without iodine. So why is that a good thing? Well, normally, if you're looking at enhancement, you want to see if there's a lesion that's metastatic, you would do a non-contrast scan, a contrast scan, and compare them. That's 2 scans, double the radiation. If you can do a virtual non-contrast, you scan once with contrast agent, and then you can remove it virtually and look to see if that enhancement occurred. Calcium suppression, I showed a little bit, and I'll show more. Remove the bone signal so you can better see the surrounding tissues or the bone marrow to look for edema or things like that. There's also uric acid. So this is really important with kidney stones. If you want to know, is that a uric acid-based stone or not, because the treatment is different. Or if you have gout, that would be more the MSK perspective. Is it a gout crystal? Is it CPPD? Something like this, then you can distinguish ideally. Or there are, you could say, a little bit more general material images. So the electron density and the Z effective. And electron density is essentially, it's the density of material independent of its atomic number. So if we would have a cyst, then this would have a higher electron density than the surrounding tissue. Z effective is the atomic number of the tissue. So if you would have iodine or a higher atomic number element, then you would see this in this map. And then the second type are the virtual monoenergetic, and that's what I mentioned as we go down in the energy. So if we would say this was a single, like a synchrotron beam, and we would move the energy down, then we would have higher contrast. If we would move it up, we would have less contrast. But the advantage with this, and I don't know if this is going to work with, oh yeah, I do have it. So the advantage of this is that we can reduce metal artifacts. I'll show that in a second, but just here again, we have a lesion in the liver, for example, very difficult to see, easy to miss. If we reduce the energy, then we can see it a lot better. And there are ways to reduce noise because going down energy will increase the noise, but because we have synchronous acquisition of the high and the low energies, we can do a spectral noise cancellation. It's anti-correlated noise. And we can keep the noise low, so we actually improve the contrast to noise ratio for these images. And if we move up to the higher mono-E's, we lose the contrast, so not normally done unless you have metal artifacts, so screws or other orthopedic hardware, things like that. You can reduce this quite a bit to see the surrounding tissue a lot better by removing the artifacts, or at least lowering. It's not completely removed, but you can lower them. So that's spectral CT. Photon counting, I'll just talk a bit quickly before going into some of the applications. Photon counting is a completely different detector. What I've talked about so far, conventional and also the spectral, are energy integrating detectors. So you have your scintillator, which will capture the X-rays. These are converted to the light signals and will then convert it to electronic signals. And this is all integrated, it's all added together, and you get your total attenuation. So it's not specific to the materials. If we have two layers of this, which is what we do with dual layer, then we can look at the two spectra, and then we can distinguish that way. But each layer even is still adding up all the signals. Photon counting uses a semiconductor. So each photon will cause electron hole pair. And this will then be collected at the anodes or the cathodes. And these are essentially pixelated anodes. They will receive the charge, and each basically hit of the photon will cause this charge. And depending on how high this charge is, will be related to the amount of energy. And this can be set so that we can put it into a certain energy bin. So starting at however many kilo electron volts. And you can have these different bins, so each photon will fall into a certain bin. What's really advantageous of this is you can actually set the first threshold above the electronic noise. So if you imagine 4 different hits of 4 different photons come in, the first one is in this bin, so bin 3. The second one is in bin 5, bin 1. But everything, all the photons are coming above this noise, so you can essentially remove a good portion of the noise. And the other advantage of this is you can essentially have this pixelated detector, so you don't have to have the septa in between. You can essentially put them right next to each other. Now, there are disadvantages of that because sometimes you'll have charge sharing, so you'll have the photon that actually is caught in both. So these are things that need to be worked out. But because of these two things, able to reduce noise and not needing the septa, you can really increase the resolution, the spatial resolution in photon counting. And of course, for MSK and bone imaging is quite interesting. The other advantage, in addition to high resolution, is K-edge imaging. So I talked very briefly about the K-edge of iodine. So again, we have our attenuation versus energy. So you have this K-edge where right at the K-edge, you have the photoelectric effect happening, and then that sort of decays as the energy increases and you have more scatter. This is too low for photon counting to work for a K-edge, so you can't, it's too much in the noise region kind of, and you can't get that low. But other elements, gadolinium, gold, bismuth, they have a higher K-edge, so you could, with the bins in photon counting, set a bin right above and below a K-edge. And then you could subtract those and get only that material. And if you have enough bins and you want to look at 2 or 3 different materials, then you can essentially say this is a phantom that had iodine, it had gadolinium, and it had gold in it in different mixtures. And you can essentially generate a very nice, clean material image from that. So that's something really exciting with photon counting, is to be able to use different contrast agents for maybe eliminating number of scans or looking at functional imaging, things like that. So we see advantages of photon counting really in any application. So of course, anywhere where you're looking at high resolution, so lung microstructure, looking at calcifications around a stent or something like this, but especially in bone. So looking at the microstructure, how well can we see changes in the bone microstructure? Can we see, but can we also start to see changes in other tissues? So the cartilage, for example, is this possible? So we see some evidence qualitatively of this, and there's a lot to be done to learn really where the advantages of this. But of course, as I mentioned, very, very high spatial resolution, and you can see that qualitatively here. And as well as the K-edge. And this is, I just wanted to show this example of the K-edge because I think it's really, really interesting that this was a study where it was looking at, these are in animals, not in humans, but I'm looking at plaque. So now gold nanoparticles that will then bind to the macrophages in the plaque, because the characterization, the material components of the plaque are very important to know, is it vulnerable, could it burst, or is it stable? And to actually have an image that is using, where you can see the iodine, so this is the vasculature, but also then a separate, in the same image, but a separate signal for the gold to see exactly where the plaques are and where the macrophages are, is really interesting. And I think could bring a lot of value for this. But we wanted to talk about MSK. So now I'll just talk a little bit about where CT is used in MSK and where we see spectral and also photon counting really changing the standard of care. How this is really starting to now, and in the future can play a much bigger role in CT imaging. So when we talk about MSK clinically, CT is used in 4 main areas: injury or trauma, inflammation, degeneration, and cancer. And not just CT, but these are really the main areas. So depending on what the problem is and what's available, different modalities will be used, and often a combination of them. So if we talk about injury or trauma, I talked already, fractures, we can see very detailed images of the fractures with CT, but of course we don't see the edema. So we can tell if there's a fracture, harder to tell if it's inflammation as well. We can see, usually we're looking at contrast uptake, but depending on the location, especially if it's close to bone, or definitely if it's close to a metal implant, it's very difficult to see any uptake of contrast to indicate inflammation. Degeneration as well. We can certainly see changes in the bone microstructure around, so the subchondral bone, for example, changes in that if we're talking about osteoarthritis or something, but changes in the cartilage morphology are much more difficult, and we would look more at MRI. Cancer as well, osteolytic lesions, osteoblastic lesions, these are what's looked for to diagnose, for example, bone metastases, multiple myeloma, but sometimes we don't see those. And then if for example, there's a suspicion of multiple myeloma, and we're not really sure with, we don't really see lytic lesions, or maybe it's not quite sure, then to determine if we're in a pre-myeloma stage, do we see changes in the bone marrow composition? And for that, at the moment, we would need something like MRI. So these are sort of how those drawbacks I talked about pertain to MSK, or limitations, not really drawbacks, but limitations of CT. So now I just wanted to show this again, when we're looking at the different materials. So I talked about, bone here, iodine is here, for example. If we're looking at MSK, this is kind of where our realm of materials. So really looking at water or blood, fat, or bone marrow, yellow marrow, and bone. So oh, this would have been a nice animation and now it's a mess. But what I wanted to show is if we would zoom into that triangle and we would want to look at these different aspects, well, any picture. So if I would have I would draw a region of interest here in the bone, and I would look where on this plot does it land. It's bone, so there's going to be some bone signal. It's a combination of red and yellow marrow, so there's some blood, there's some fatty tissue. So it's going to be somewhere in here. And if I would want to know the bone density, well, that's going to be sort of how far along this bone water vector that is. But if I'm more interested in the fat and water content, the marrow composition, that's sort of this vector here. And if I'm maybe interested in muscle, okay, there's no bone, then I'm probably looking more at a fat water line, and I'm looking here. So for example, if I'm looking at a fracture in bone, so maybe healthy bone is probably more fatty, so it's around here, but as edema comes in, there's an acute fracture, this point will move over, even if the bone mineral density doesn't change that much. BMD, I'm not as much concerned about the marrow fat if I'm only BMD, and then I can look sort of how long this is, but maybe I'm concerned about marrow fat because we know that will also affect bone health, and I can look at that here. So this kind of pertains or alludes to some of the areas where we see potential for Spectral and MSK, so these are some of the areas I would say we see it. So I'll just quickly go through here. Bone mineral density fractures, bone marrow. I talked about looking at edema or fat. Joint imaging, can we see changes in cartilage morphometry, disc herniations, ligament tears, things like that. Muscle, can we see fat fractions or things like that. So I'll talk a little bit about what's been done, where we're kind of going. Oh, but first I'll talk about photon counting. So here also, photon counting has a full sort of spectral availability so we have a prototype scanner that we're working on in France. And for this, we can generate spectral images, getting photoelectric and Compton scatter, but we can also look at high resolution. So this is where, in addition to the spectral benefits, we can look more in detail at joint morphology, at bone microstructure, things like this. But in addition, K-edge imaging. So what might be interesting is, does this enhance our ability to see inflammation? So can we generate a K-edge of the inflammation? And maybe this is helping where we would normally have artifacts from beam hardening or from metal artifacts or things like that. And also the material maps. Can we have additional material maps for this? So with bone, where we're working, where we've done some studies is with what I had just shown on the volumetric BMD. So doing a material decomposition to see how much bone mineral density we have from the spectral scan, but also looking at 2D BMD. So essentially when you do a CT scan, you do a survey scan first. So you do basically you do essentially an X-ray of the patient, and you see, where do I need to do my scan? And then you focus in on that. Because we have a dual layer technology, even our surveys also have that information. So the idea is, well, if we have two energy spectra from our survey scans, that's kind of like a DEXA. We already have that information. Can we generate a BMD map from this? So that's a research project we're working on to get basically a BMD for free. So anyone who gets a CT scan anyways, but would get a BMD score. And this is really relevant because, and I have a slide on this in a second to show that a lot of people have, and I think a lot of people here know this, osteoporosis that's not being detected, and they're getting CT scans. There's for something else maybe, but they're getting CT scans and they don't know they have osteoporosis. Bone marrow, so looking at fractures, acute versus old fractures. I talked about bone metastases or primary bone cancers and bone and joint morphology. So just in a bit more detail, so bone mineral density, I think, I don't need to explain this to anyone. I think probably everyone knows DEXA. Dual X-ray absorbed geometry is sort of the gold standard, has a lot of limitations. because it's 2D, you have calcifications in front, or you're not dependent on patient size, things like that. So QCT, quantitative CT, is much more predictive of fracture risk, but you still need a phantom to scan. So both of these modalities really are dedicated. We think somebody has osteoporosis, so we'll do this. But this is what I was alluding to. Right around half the people that have osteoporosis don't know it. And there's other studies, I don't have it here, but that have shown a really high percentage of people that are getting a CT scan for something. If they went back and looked to see, does this person have a fracture even, or do they have osteoporosis? And they did. So there, I think, is a big opportunity here that if because this is what's resulting in this treatment gap of osteoporosis, that we could narrow this by already detecting in these patients low bone mass, because we have all the information. It's already there. We need to get it. So here we could, from the scan, get the BMD, and then would have that score. So some people have been working on this already. There's been a number of publications looking at, so this is actually, I showed photoelectric and Compton scatter, but you could also look at the monoenergetic images, a high and a low monoenergetic image, and it gives you a very similar pattern. So, so there's been studies looking at this, plotting a high and a low monoenergetic image, looking at where the pixels land in this plot, and basically generating a curve for BMD that way. And there's been studies looking at excised specimens, or even some patient studies looking at this, where they've shown quite a good correlation to QCT. Now, what's interesting is this is sort of the two materials, like a water bone sort of decomposition. But I think there's a lot of potential with Spectral, because I showed the triangle here. We could also look at the marrow composition here, and we know that if patients have a high fatty content in their marrow, their BMD will be underestimated because of the fatty content reducing the Hounsfield unit. And this could be maybe, this error could be corrected for if we know how much fatty tissue they have in their marrow. So that could be an interesting step forward as well. So fracture, I talked about a little, and here are just some examples. So again, we have a conventional image. We see the fracture very nicely, but if we apply a calcium suppression, then we can see, okay, it's acute, because we see the bone marrow edema. And this is another study we worked on, looking actually at the Compton scatter. We developed a method using that as well. This was a study using calcium suppression. This was actually using an edema map that we tried to develop, comparing to MRI. This is the water image of the MRI, and we could see the edema quite nicely. This is a study out of Munich, where they actually did a 3-material decomposition from the monoenergetic images. So they have basically a water map, a fat map, and a bone map. So they wanted to look at bone marrow edema, which you see quite nicely here. But theoretically, you could also look at marrow composition, or even BMD with that, because they have the maps for it. And this was a study, it's not really bone necessarily, but I think is an interesting application of Spectral that we worked on in Kiel in Germany, where prevertebral hematoma. So you have a fracture, but you have a bleed in sort of in front of the vertebra. And detecting this is really difficult in CT, because you have the hematoma will basically, it's coagulated blood, so it'll increase a bit in density. The atomic number doesn't change much, and the Hounsfield unit doesn't change all that much. It can be very difficult to see. But because you have this change in density of this static blood, you can see it quite nicely in the electron density. So that's sort of eliminating this atomic number aspect of the Hounsfield unit, and just looking at the density changes. And here we could show that it was actually really increasing the diagnostic accuracy. And this is just a comparison to the MRI as well. Cancer, I showed very briefly, but looking at, for example, detection and characterization of is a lesion metastatic, looking at conventional imaging and different levels of calcium suppression. So I didn't actually explain that here, but just really quickly back here, this bone vector is quite wide. because we have different components in the bone, we have different types of bone. So the calcium suppression is basically is able to sort of accommodate what level of suppression do I want to do, how much bone do I want to suppress. And so they looked a little bit into that in Cologne, and they just looked at, for example, a low level, so which actually corresponds to a lot of suppression, versus a medium or a high. And so, but with this quite a lot of calcium suppression, they could really see and delineate the metastases, and they could characterize them much more accurately in terms of sensitivity and specificity compared to conventional imaging. And also looking at patients with multiple myeloma, and comparing to PET. So looking at basically patients, looking at the activity, the viability of the cancer, and how well this could be seen in conventional CT or spectral CT. So they had patients that were that had both scans, so the nuclear medicine and the CT, and they compared the in patients where they had basically PET negative, so not viable, and PET positive, viable, and looking at the difference in contrast from a conventional versus a calcium suppressed. And they could see a much higher contrast, and for that, a much higher diagnostic accuracy with the calcium suppressed images. And this one is looking at actually iodine maps in the bone, which is really quite tricky. And this was sort of an experiment that I think is really interesting, and could, there's a lot of work needed in this, because iodine, separating iodine and bone is still quite tricky. But this was looking at iodine density to see, because of course, if you have cancer lesion, a tumor, metastasis, it's highly vascularized and it's taking up a lot of iodine. So how well could this be seen? And could it be differentiated from, a nodule or something where, okay, it's dense, but it's not vascularized. So how well do we see iodine uptake versus not? So, and again, seeing an increased diagnostic accuracy with iodine density maps in the bone. And then moving on to joint imaging, and I'll try to go quick because I know we're running low on time here. So the discs, I showed one image. So this is sort of just another example where really difficult to see a herniation. We see it in the MRI. We don't see it in the conventional really, but if we use a calcium suppression, all of a sudden we can see it quite well. I think electron density would be quite interesting to see here. Cartilage morphology, again, looking at a calcium suppressed image and comparing it to the proton density weighted MRI image, you can see the lesion, the really thin layer of cartilage versus the surrounding, similar to what we see in the MRI. This was just an experiment I did with the electron density image of to see if I could see a ligament, a ligament, and or the meniscus. So and the reason why I think this could work is again, we're looking at the density. So forgetting about atomic number, but just the density. So a ligament versus the surrounding tissue, synovial fluid or something like this should be denser, and how well can we see it? And I think we can see it, but the question is, can we see a tear or something like that? I think that's really where the question is. But or maybe in the discs, is there water loss or something like that? And of course, with photon counting, I talked about this already. Seeing, okay, do we see cartilage? Can we see the morphology? Can we see lesions? Most importantly, so these are things where I think there's potential, but definitely need to be explored. And the last thing I wanted to talk about was muscle. We're doing a little bit of work on this as well, looking at things like muscle fat fraction. So in patients where we have sarcopenia and there's a lot of fat infiltration, this is difficult to see, especially if you have contrast agent. So contrast agent will enhance the tissue, and then the subtle changes in Hansen unit from fat and water will be very difficult to see. So can we use spectral imaging to eliminate the iodine signal of the contrast? Can we look at the fat muscle, fat water sort of, or fat muscle difference? And also, I think we're looking a bit into muscle edema as well. So this would be another topic in this. So yeah, that's what I wanted to show. I tried to keep it short. But yeah, just to summarize, we see CT, conventional CT is very, very critical in radiology, but it has its drawbacks, soft tissue contrast, ionizing radiation. And with spectral CT, we can start to tackle these things. We can reduce radiation. I didn't really talk about that, but as we have higher contrast with the low energy monoenergetic images, we can boost the contrast, but we can also lower the radiation dose. We can reduce the current or to reduce the radiation dose. So we can also improve the soft tissue contrast with things like calcium suppression or with iodine maps, things like that. Photon counting CT, similar, but we also have higher spatial resolution, and K-edge imaging that are sort of emerging as showing a lot of promise in clinical imaging. And in terms of MSK, we see really in all of these images and also new sort of developments that we're doing potential for improving the added value of spectral CT and multi-energy CT in the clinic. Yeah, so that's what I had. And I don't know if there's time for questions, but if there are, I'm happy to answer.
Thank you so much. Sorry. Thank you so much.